pick that audio.
To figure out, to do a troubleshoot to figure out.
And then just listen to see, can you hear me? Can you hear me talking? You can hear me? Cool. And everything else is good. Go ahead, take this off one. Take that off one. You see it says one right? Go ahead, clear that.
It could be
No, just
something
hit
that
one.
someone brought an infected device in, and that was blocking everything to keep that affected.
There we go. So that's gonna be, so that's gonna turn that off.
This is one thing that I talk about putting up a mesh, because a mesh protects it. You know, we talk about.
Really? All right, so again, thank you all, the brothers. You know, it's always good to be with the brothers. And again, as y'all know, February is Heart Health Month. It's one of those things where when we look at heart health and how it impacts African Americans, especially African American males, we oftentimes take a step back. You know, when you think about how it impacts us from a risk standpoint, how it impacts us from an access standpoint, and, you know, with the Damar Hamlin thing, it really puts us in a space where we have to understand that we all are vulnerable. So as I was going through that and thinking about what that meant, it really was an opportunity for me to look at what we're doing, how we're doing it, and to say, what are 5 things, right, that I wish patients knew, that I wish I knew, that as we start to interact with our healthcare professionals, you know, these are the things that really are going to allow us to move forward. Next slide, please. All right, I don't have any disclosures. Next slide. Again, this is just my views, not the views of any organization or entity I'm affiliated with. Next slide, please. All right, so again, a little blurry, but what we'll do, we'll focus on kind of this shifting idea of where cardiovascular disease has gone from our approach to being reactive and being proactive. We'll talk about kind of the 5 benefits to a plant-based diet. We'll talk about this shifting idea of, in the old days, we used to wait until we had the vulnerable plaque. That means you've already had the underlying issues that could cause a heart attack, and then we fix you. Well, now we're looking for the vulnerable patient. And then we'll shift to some other strategies about how to build that for yourself, right? Because for me, I want to empower the patients that I have that don't rely on seeing me, let's say, once or twice a year or something like that, so that they can say, hey, I'm empowered, I can make these decisions and get to Dr. Bass that next time. Next slide, please. So again, we'll go through an introduction. We'll talk about why it's important. You all know me, but for those who don't, we'll get a little bit of that. And then we'll move right into that discussion, right? So we're going to go through the nose. And when you leave out of here, you're going to be empowered. So I don't want anybody, the next Kappa function we have, I don't want people, hey, I don't really eat like this. You know how you're supposed to eat. You know what you're supposed to be doing, right? We're going to talk tonight. So y'all go keep it real. Next slide, please. All right. So as you all know, I went to the University of North Carolina at Chapel Hill. I am a Tar Heel. But I'm also a Jay. I was a Jayhawk first, mainly the Mu chapter. I'm a Mu chapter brother, fall 97. But now, you know, my role has shifted, right? So my goal is really preventive cardiology through the lens of nutrition, exercise, fitness, and I'm also a sports cardiologist. So I look at the benefits and the potential risk of intense athletic exercise and how to optimize that. Next slide, please. I was the most likely, y'all might not know I got this award, I was the most likely to quit medicine and play a professional sport. It wasn't that I was this great athlete, it was just in medical school, I was still training, I was still lifting, I was still doing all those things that an athlete would do, because I still have that athlete mindset. Next slide. But as you all know, I'm a dad, I'm a husband. That's me many, many years ago when I was at the University of Kansas running track. I was about 4% body fat. I mean, I was a monster. I look back on that and I say, man, I'm scared of myself. Next slide, please. But I also do some work at restaurants talking about the benefits of plant-based diet, working with athletes, and then also in the film space. Next slide. And most of the research that you're going to see if you Google or look for the research is going to be based in nutrition, based in how do you optimize nutrition, how do you make decisions. And tonight, as we pull one piece apart, that's what we're going to dig into. We're going to dig into how nutrition can optimize your health. Next slide. All right, so how many people know what the leading cause of death in the United States is? How many people? All right, we got 1, right? And that's the general response, right? Oh, prostate cancer, or lung. No, it is heart disease. What about in the world? What's the leading cause of deaths in the world? Heart disease, right? But if you look at how, and I like that we're starting, because when you look at how much energy we put, okay, think about this. Heart disease gets 1 month, and it's the shortest month, but we kill the most amount of people. Right now, we've been talking about 3 or 4 minutes, right? 3 or 4 minutes. And in that 3 or 4 minutes, 3 or 4 minutes, that's about what? 60, 30 seconds, 30 seconds block. Every 34 seconds, someone dies of a cardiovascular illness. 34 seconds. We've been sitting here and people have been succumbing to cardiovascular disease. Next slide, please. So overall, this is ischemic heart disease at the top. So ischemic heart disease and stroke, you can add up all the other causes of death, multiply them by 2, and they still don't equal that same amount. Next slide, please. So when we look at heart disease, where is it centralized? Where is it localized? Oh, y'all don't want to say it because y'all scared. The South, right? How many of us in this room was from the South? Half the room, right? Half the room. We're going to talk about what the limitations of the Southern diet are in that space. That's what we're going to talk about. Next slide. Next slide. That just goes on. All right, so this is us as a cardiology service feeling good, right? So you can see that green line represents heart disease going up. And you can see that it's starting to trend down. You said, Dr. Bash, y'all did a great job, man, brother, great job. But if you look, next slide, it's starting to tick back up. Now, why do you think we're starting to see that uptrend? Why do you think that's occurring? Complacency, right? What else? Y'all gonna have to talk to me tonight. I've been working on. I heard somebody say diet, right? What else? Sedentary. Hit the button. Let's see. Y'all already know. Hit the button. Come on, next slide. Hit it. Boom, right there. Diet, inactivity, and weight. Over time, that's occurred. And that's that complacent attitude, not blaming, right? I'm in that same group. So it's one of those things where we really have to move to a different space and understand how it's impacting us. Next slide, please. So sometimes as a physician, this is how I feel, right? I feel like, I can't reach up and turn off the faucet because I'm just cleaning up the water, right? Oh, doc, I forgot to take my meds. Oh, which meds? The blue one, the orange one, right? I have patients that just don't have, they want to feel better, they want to get better, but they don't have the tools. And I'm not saying that being accusatory. I was the same way, right? I'll tell y'all a story in a little bit of when I had to get my perfusion test and my heart cath. Yeah, y'all didn't know. That's how I can feel what y'all feel, because I've been in the same boat. I'm where you were, hence the reason why I changed, because I knew that lifestyle was the key contributor to that. Next slide. So I thought this was a talk on lifestyle and how to get better. It is. Next slide. But when we do it, let's hop in the case. Now, go ahead and hit that slide. So you all can't see, but this is a cross-section of an MRI. And as you look, and I should have brought my pointer, but overall, there's an area here. I can use a shadow right here. That's his heart right there. And the heart's supposed to open and close, right? What's his heart doing? It's just wiggling. So this was a 48-year-old male. Yeah, 48-year-old male with a history of hypertension, and everything his doctor told him was mild. Oh, you got mild cholesterol. Oh, you got pre-diabetes. Oh, your blood pressure, you're African-American and you have muscle. That's why it's up. So he thought he was good. He thought he was cool until he had to see me, and I had to say, hey, your ejection fraction, which is normally supposed to be 50, 60%, is now in the 15s, now in the 20s. He couldn't brush his hair without getting tired. He couldn't enjoy his time with his family. And so in talking to him, he said, ultimately, what did I do wrong, doc? Next slide. Next slide. And so we did his studies, and ultimately what we found out that his heart was probably working at about 10% capacity. Whenever that happens, you have a few options. We could treat you with medicines, and hopefully you'll heal, but only about 30% of patients do. We could put you on a transplant list, which again carries a whole source of other issues, or you just try to do the best you can. We took a different approach with him, and if you stay tuned, we'll tell you what happened at the end. Next slide. So ultimately, his question to me was, these are the list of medicines, and I know it doesn't project well, but 1, 2, 3, 4, 5, 6. So he went from taking no meds, having having mild, having this, to leaving with a grocery bag of medications. A whole meal of medicines is where he is right now. Think about what that does to his mindset. And this was a brother. This is a brother. Not that it makes a difference, because I approach all my patients the same, but for him, he was always told he was healthy, right? Military, right? He did everything he was supposed to do. So now he's at that time, he 2 years after retirement, right? And so that was what was tough. Next slide. And that's this question he asked as he sat in his hospital bed. What did I do wrong? Why didn't I make these choices before? And the thing was, he said, what choices would I make? Because everything everyone told me was, it's mild. It's pre-diabetes. It's these things. So he didn't have a reason to act because he didn't know. And that's what prompted me to say, what are the 5 things that we have to know to protect ourselves? Next slide. So when we think about prevention, next slide. Next slide. Next slide. All right, when we think about prevention, there are a few levels, right? So we'll get to the nose. But the first thing is there are 4 levels of prevention, right? The first one is primordial. Primordial is when your kids see you sit at home eating pizza, or see me sit at home, I don't eat pizza, but eating pizza, doing this, doing that, right? They're learning those behaviors, right? So primordial is before you have risk factors, before you have disease. Then there's primary. That means that's where I am. And I ain't afraid to say I got a little I got hypertension, right? I don't have cholesterol, right? Because I'm plant-based, that's the beauty of it. But I know that if I don't control my high blood pressure, guess what? That next step is secondary. That means I'm gonna develop disease based on that risk factor. And then after that, once I have that disease manifestation, guess what? Then the complications come. So ideally, if we could identify those people who are potentially at risk, right? Kids. I have a program called Jump Right In where I go into elementary schools and talk to kids about healthy lifestyle, because I know if I can change one kid, guess what that kid's gonna do? He's gonna go back to his parents and say, hey, I don't wanna eat ramen noodles because they have 2,000 milligrams of sodium in one serving, right? I don't wanna do that. Now, we do have some constraints, right? We understand that, social inequities make stuff difficult, but those are the things that we should do. Next slide, please. Again, this is a pathway for prevention. Looks super complex. I show my patients this, they say, okay, where do I start? And I say, don't worry about that. We're gonna work through it because again, it's a step. That first step is making the decision to ultimately say, I'm gonna make a change. Next slide. So this is that evolution of risk is an evolution of thought, right? Don't wait. It's just like you knowing your tire is bald, but you rolling the dice gonna make that trip to Houston. I'm gonna talk real, right? We're gonna talk real, right? And you wouldn't do that. You wouldn't say, you know what, I'm gonna drive 3 hours on a bald tire with the hope that the Lord gonna make a way. He will, don't get me wrong. Won't he do it? Yes, he will. But at the same time, he gives us wisdom, knowledge, and understanding to say, okay, I know that something could go wrong. Let me start to look at it. And that's where our shift in medicine has started to occur, right? We ultimately have said, why are we waiting for people to have disease and have complications before we decide to fix them? Next slide. So who is at risk, right? That's the next area we're gonna talk about. All of us are. But let's start with, what is this? Our children. These are the obesity rates in children over time, right? They have ages 2 to 3, 6 to 11, 11 to 12. And over time, over these past 50 years, what have they all done? Gone up. He said gotten fat. I can't say, just say it out here. They have gotten fat. All right, next slide, please. I'm trying to be nice with it. Now, even what's more concerning is, what group do you think is mostly affected by this trend? Black and brown, right? We leading in something. Most obese, most sedentary. Next slide, please. And how do they develop that risk? When they see dad do it or mom do it, bam, they do it. Next slide. When they see dad come home, sit, bam, next slide. Boom, same behaviors. Next slide. Next slide, please. And so overall, what we know, so this is a study that looked at, and we don't have a whole lot of studies, I want to make it plain, but they said childhood obesity is one of the key indicators to when you have your first stroke. Next slide. And so this study was concerning because at the time, and my son always hates when but he was getting evaluated. This is when he was younger and he was on that borderline. And I knew the data that, when the first time when you're labeled overweight or obese is basically shortening the time when you'll have your first stroke, when you'll be diagnosed with hypertension. So you're narrowing that time. And so as a father, I said, okay, I got to figure something out. I can't go as extreme as my dad did, but it helped me to understand that we really need to start to take this seriously. Next slide. So we used to call how many people know what we used to call type 2 diabetes? Adult onset, right? Then we call it sugar, the adult onset, but you got it when you were older. What if I told you that the reason why they changed the name is because the diagnosis started occurring younger and younger and younger? How young do you think the youngest person was that's been diagnosed with adult onset diabetes?
10, 2, 3.
3 years old. 3 years old. Right down the road in Houston, right? Right down the road. This is an article about them, and they couldn't believe because it was the first time. And how do you tell a 2 or 3 year old, hey, what? And again, a lot of it is what they're getting. Next slide, please. So, and not to say, not to be morbid, but once you have diabetes, your life expectancy decreases by 5 to 10 years. So that child is 3 years old right now. And the longer he has that risk, the lower his life expectancy is. Next slide. Now, we know that there's inequities in healthcare. Next slide. There's a ton of hurdles, but ultimately, education is the most powerful weapon which you can use to change the world. And that's what we're going to do today. You know, again, this is a start, or the jump-off point to a program where we want to focus on these 4 paradigms of health. The first one, we're talking about physical. We understand that there is mental health. We know that there is spiritual, but another piece that we do need to touch on is financial. So over the next several months, we'll roll out products that really help not only the brothers, but the community. But this is a very inward-facing movement. Next slide. All right, so the first thing you need to know is know your history. All right, how many people know, if you are on meds, and your hands won't be shown on camera unless you cut to it, unless you cut to the camera, get ready. How many people know all of their medical conditions? Know all of them? Okay, we got 1. We got 2. Okay, you see, I'm not even raising my hand. I got some. Hey, my wife had, didn't she tell you? She said something, so I ain't immune, right? Okay, not you gonna tell you, but sometimes I don't even remember, and I'm a doctor, the medicines. and I'm not laughing because it's funny, but I'm thinking back, I'm like, am I? I stopped taking that. But it's one of those things where those are the tough things, but knowing that history is important. All right, y'all ready for another? How many people know their family history? All right, and I like the fact that it's so, and I'm seeing a lot of hands do this. I'm saying, God, well, we don't really be sharing our business like that. Next slide, please. And so when we think about, and again, I'll hand this to you, next slide. The things that are important when you go to the doctor, ultimately this says knowing your medications, knowing your diagnoses, knowing your procedures, knowing all the things that they have on a sheet that you can take a picture with your phone, but the doctor didn't get. I had one patient say, well, the doctor didn't tell me what my diagnoses were. I said, just ask them. We're not holding that information hostage. We don't get anything from holding that hostage. If anything, it doesn't allow you to really understand the direction that your healthcare needs to go. Next slide, please. So if you needed to know all, right, these are all of the histories that you need to know. Your medical history, everything that's going on. Your procedural history, your medication history, and your allergy history. Am I forgetting something? I said it earlier.
Family history.
Next slide. You got it. Next slide, right? So just have a conversation. I talked with my brother today. I have 2 older brothers, and he said it was okay that I shared this. And my sister-in-law, her family, unfortunately, has a history of kind of folks dying suddenly, unfortunately. And when he was just having a conversation, it came about that they realized 2, 3, 4, 5, 6 folks all had the same condition, but because we never talked about it, no one ever knew. And what that means is that for them, they're reframing what they think about their cardiovascular risk. And so as we talked on the phone, he said, well, how do we miss that? And again, that's not something that comes up. I mean, it's always interesting when I come and hang with the brothers and I'm at the house and, I'm seeing, brother, hey, let me ask you a question. They'll tell me more stuff. I'm like, well, man, but at the same time, no, which is fine. But have that same conversation with your family members. Have that same conversation with folks so they can understand where you are. Next slide, please. And so know your symptoms. All right, before we go on, how many people know the signs and symptoms of a heart attack? How many people know it? Of course, I know it. I'm a cardiologist. So, all right. Do you think it would be important to be able to say, hey, all right, I think something's going on, right? It's important. But in a regular clinic visit, now, granted, even though you're seeing a heart doctor, that's not something that I routinely say, okay, these are the signs and symptoms, because the visit isn't structured that way. And so that's where, as a patient, it's not necessarily on you to know, because you're like, well, man, I'm paying a doctor to help. But by the time, you're going to know outside of the office, so you have to make those decisions to get there. Next slide, please. All right, so you can't see it, but this is a text message, and I had to pause from one of my patients, and it was a few years ago, and it leads in saying, Sorry to bother you. It's just before Christmas. My son just died. Her son was in his late 30s. Much younger than me. I met him before. But the reason is because one of the complications of high blood pressure. He didn't take his medicines. He talked about how, it was so sudden that we really didn't expect it. He was not taking his medicines or eating right, and we'll just take it one day at a time. Right? He had a massive stroke, and it was very challenging. And I work with, and she was my patient. He wasn't. But she said, I want you to make sure you tell people that something so small as not taking your blood pressure can have a big impact, not only on you, but also on the family. Next slide, please. And so when we think about heart attack and the signs and symptoms, right, you look here and tough to make out, and I keep saying that, but it is what it is. Ultimately, again, shortness of breath, chest pain, sweating. And the reason why you see blue and pink is because men and women sometimes present in different ways, right? So on Saturday, I'll be having a discussion with women, which is great, to talk about heart disease and women. Now, men are invited, of course, but we're going to have that discussion to make sure that they understand that the things that they brush off, oh, that's probably nothing, could be a serious heart event. Next slide, please. And so as we look at knowing the signs, right, they talk about chest pain, they talk about shortness of breath, they talk about pain in the shoulders, arm, jaw. For women, sometimes it can be dizziness, nausea, vomiting, other things like that increase their concerns and increase their risk. Next slide, please. And so I pulled this out because this is, and that graphic down at the bottom actually says, retiring from the military is a risk factor for heart disease for women, which I didn't know. Last year, the militaryhealth.com, they asked me to put together a little graphic about the differences in heart attack presentations for men and women. And what I found was, I was surprised, right? I always approached it the same way, but understanding that it's not necessarily the difference in symptoms, but it's how they articulate or how they talk about those symptoms and how they describe them to the provider to say, okay, this is what I'm having. This is what the problem is. Next slide. And so ultimately, this is a quote from me saying that, although we realize that there are differences, it shouldn't affect our treatment. And what you see is that if a man and a woman unfortunately present to the emergency department, and this is changing now with similar symptoms, because the woman, just by the sheer fact that she's a woman, is often considered lower risk, many times, you already know where I'm going, she doesn't get the same aggressive treatment, right? Now, that's changing, right? We realize that is a healthcare disparity, but that's something that when you talk to your wives, your daughters, your sisters, all those different things, make sure that they push the envelope, right? Because a lot of times, it's stress. Stress can certainly make you feel chest pain, but at the end of the day, still evaluate them the same way. Next slide, please. So, know your risk. So we went through know your history, know your symptoms, know your risk. How many people in here feel like they're at risk for heart disease? All right, good. I like that. Most of the room is saying, okay, and we all are. Number one, we're male. Number two, we're African American. Number three, other than maybe one of us, we're a little more mature in age. I'm not old, I'm just mature, right? I done lived a little bit. Next slide, please. So when we think about heart disease, now what are those risk factors for heart disease again? What are they? Because a lot of times my patients act surprised. Oh, really? So what are some risk factors? Y'all yell them out. Cut to that second shot. Inactivity, all right. What else? Diet, all right. What else? Weight, all right. What else? Y'all knocking them out. So I don't even need to hear nothing at the next rap meet. He said diet. What are some diseases that? High cholesterol. What else? High blood pressure. What's another one? The next big one for us? Diabetes, the sugar, right? We got it, right? So again, one of those things, go ahead and hit it. So y'all don't even need the information from the CDC. Diabetes, overweight, unhealthy diet, physical inactivity, and they got excessive alcohol use. But all of those things are risk factors for heart disease. Next slide, please. Y'all already know. This is easy. Now we're going to shift, right? So we talked about knowing your history. We talked about knowing your symptoms. We talked about, knowing where you fall from a risk standpoint. But now we're going to do something about it, right? Because it doesn't do any good to have all that knowledge and it just sit on your hands. Next slide, please. And so the difficulty about making that change, y'all ready? You got to take a chance. Game time, you got to take a chance. That's the hardest part. Because I'm so used, I won't even put it on y'all. I'm so used to doing the same thing, the same way, the same time, all the time. I get comfortable in that space that it wasn't until I had to break out and had to adjust those things that I started to see the benefit of it. Next slide, please. So this is one of my patients that when they come to weight, you know, there's a familiar poster on my wall that talks about transitioning your diet to a whole food plant-based diet. And they always give me a little bit of grief. And I don't force people to be plant forward or plant-based. I just want them to think about things differently. Think about what their plate looks like, understanding that I've been where you've been, right? I'm from the South. I understand how good that food is. Next slide, please. But pills and surgery, that's a quick fix, right? If that's the choice that you want to make, and I don't force people. I had one patient, I said, hey, sir, your cholesterol is this high, I can give you a medicine, or, for the next 12 weeks, we could do extensive lifestyle changes, we could do this. And he's like, doc, where do I pick that medicine up at? I said, sir, at least. He said, no, I'm fine. But, and now, personal choice. But the lifestyle change is tough. And I tell people, it takes time. It's not something where you come to see me once and you like, oh man, I'm so inspired, I'm gonna throw all this stuff out my cabin, I'm not gonna do this. No, make it be sustainable over time. Next slide, please. And so the question that I ask people is, did you take your meds? And I said, I know you're saying, well, Dr. Bass, I thought you weren't gonna give meds. I don't like medications, but meds is a little different, right? It's the pillars of lifestyle medicine. Next slide. And you're saying, no, I don't want medications. Next slide. And you're wondering, what you talking about, Willis? You just told me these are pillars of lifestyle, all right? So next slide. So meds are made up of a few categories, right? So you have mind, body health, exercise, diet, sleep hygiene, social connectedness, and getting rid of risky substances, right? So those are the things that make up the MEDSSS. And I don't tell you to tackle all those things at once, right? Don't tackle all of them at once. Pick two. I typically say pick the easiest and pick what you think is going to be the hardest. Always with a handle on mindfulness, understanding how to relax, how to get into a new space. So we're going to work through one of them. Next slide, please. So what is lifestyle medicine? Next slide. So as I mentioned, lifestyle medicine, let's blow this up a little bit. Next slide. Is the evidence-based practice of helping individuals and families adopt and sustain a healthy lifestyle. So he already showed you. I was going to show you I'm a lifestyle superhero. Next slide. Next slide. So again, and so I did that because I wanted to champion lifestyle, right? I think I'm not going to say it this way. It is easier for me to give you a medicine and make that appointment be 3 minutes, right? I want to challenge myself. I want to challenge my patients to do something that they've never done, right? I want to challenge them to say, you know what? Maybe I will take a Zumba class with Dr. Bass. You know what? Maybe I will start kickboxing or whatever. Just challenge themselves to take that next step because remember, what do you have to do if you want to change? You got to take a chance, right? You got to take a chance on doing something new. Next slide, please. And so again, when I asked, did you take your meds? Next slide. We're going to do some lifestyle practice. So of that list, of those meds, who says that, diet is the hardest for them? Who says that diet is pretty hard? Or all y'all can go plant-based? Okay, I'm about to say, hold on now, they done said they can all go plant-based. I want to get this on record. Everybody, no, doctors, sign me up for that tofu burger. I've been looking forward to it. That's all good. Okay, all right, everybody like, nah, we wrap. That's a wrap. All right, next slide. So we're going to work through nutrition. So this is a good old Southern plate. Now, this wasn't my plate. This was a friend of mine. Go back, thanks. So again, he got red beans and rice. He got, again, I think there's pork in that. He got fried cornbread. He got fried cabbage, and I know that there's sausage in that. That's a big pork chop, and that's a ham loin of some sort. Next slide. Now, I'm not immune, right? I got a Southern mother who is cooking on the stove. Those are fried, delicious Ancient Mama pancakes with butter and high fructose corn syrup. That's my son right there, tan him up. Ain't nothing on that green. This was many moons ago, but I still feel connected to it. That's why I say I ain't. It's almost like New Jack. It be calling me. It does, right? It does, right? I try to calm it down, but it's hard. It calls me. Next slide. So I understand that this song harkened me back to a place, right? Next slide. Because I had the days where I used to have beans, greens, tomatoes, yams. That was me right now. I like that first line, but when she went into lambs, rams, hogs, dogs, I didn't know nothing about that. Next slide. But I know that it's a challenge. But now that I understand that delicious Southern diet leads to a 56% higher risk of heart disease, a 50% increased rate of death, a 30% increased risk of stroke. Not to bring the moment down, but it had me take a step back. And this was a study that was done in the South. It was the Regard trial that looked at regional differences in diet and how they impact health. And where do you think most of these numbers came from? Mississippi, Alabama, Georgia, all the places we from. You name it. That delicious southern belt that keeps expanding because we keep eating like this. Next slide, please. And so when we look at disease prevention or through nutrition, it's a challenge, and I know that. Next slide. So these are some barriers. Next slide. We'll blow those up a little bit. But this was an article that we came out with where we really wanted to dive into the controversies with nutrition. And we didn't make it complex. Ultimately, what we said was that, next slide. Ultimately, what we said was that you could think about foods in three categories, right? Ultra-processed, minimally processed, and not processed. You said, well, hold on, you didn't talk about plant-based or not. But this is where we took a step back and said, well, if your transition to a plant-based diet is only eating ultra-processed foods, we know that long-term, that probably isn't a good transition, right? Now, do I have, one of the Impossibles or Beyonds, once a month or so? Yeah, that's a cheat meal, right? But I understand that I can't make that be the staple of my diet, because go into the grocery store, grab your Beyond, grab your regular beef or whatever you're comparing it to, and just look at the back. Look at the sodium, look at the fat, and then look at the things. I tell my patients, if you can't pronounce the ingredients in the food that you're eating, you probably don't need, if you got to ask Siri what is dimethyl then you don't probably need to be eating it. Next slide, please. And so, next slide. So simply put, ultimately, we have to stop eating crap, right? Carbonated beverages, refined sugars. I know, all this sounds good. Artificial foods, and again, processed foods. If we stop that and just ate real food, I'm telling you, you feel a whole lot better. You start to see certain things, weight coming off. You start to see those changes occur. Next slide. And so overall, next slide, we simplify these lists for patients to say, again, anything without artificial ingredients. So for instance, if you're gonna eat a potato, right? If you're gonna eat, again, an apple, eat an apple. Now, you can add stuff to it, fry it up, you can repurpose that thing. You can do, like if, one of my buddies said, well, man, I get all my vegetables off the shelf. I said, off the shelf? But he wasn't even talking about cans. He was talking about bags. I'm like, bags?